Hi guys, finally finished with this project. Thank goodness. I did HIV and AIDS in older adults. I posted a couple very short videos just on HIV and AIDS in the elderly that you can look at if you feel like it. The first few slides are mainly statistics, and over half of all the HIV cases in the US are actually over 50 years old. Although new diagnoses are declining, 1 in 6 new cases are over 50, and that was a stat from 2016. Let's see, and then there's more specific stats on that. And then this chart down here just gives the breakdown of HIV patients in the US and dependent areas. And then this graph breaks down the number of diagnoses of HIV. And most importantly, the red columns are 50 years and older of the diagnoses. These are some of the challenges to older people with HIV. Sometimes they are already in the late stages of infection when they are diagnosed. There's a lack of knowledge to risk factors, like they think they're kind of unaware or tend to be unaware about testing and don't ask their doctors for it. There's a stigma attached, of course, with HIV. It's still kind of a tricky subject for many. It was a disease that started out as a gay disease and still has that stigma attached. There's also an increased risk of other diseases for older patients. Like I said, discrimination with this diagnosis, especially in the homosexual community. And then substance abuse is also an issue. This is additional facts. Older males is the fastest growing population with AIDS. The primary transmission is sexual intercourse. Older women tend to think because they won't get pregnant, there's no need for safe sex. And the list goes on, you guys can read. Let's see, there's other ones. There's an increase in the baby boomer population and erectile dysfunction meds, so that increases HIV risk, both of those factors. There's stereotypes with a lack of information limiting older adults on the topic of HIV. There's the characteristics. Older adults with HIV tend to have less support, medical care services than as do younger people with HIV. And then there's social and cultural differences and also lower levels of physical functioning. That's kind of a big one. These next two slides are connecting the NASW Code of Ethics. So I included social justice and dignity and worth. You guys can read this section. I'm not going to read it all because my video would be way too long. But in summary, under social justice, I just wrote about the stigma and the discrimination against people in general with HIV and how social workers need to make an effort to speak out against discrimination and injustice. And then under dignity and worth, social workers uphold individuals' dignity and worth in a caring and respectful manner. And this is the case when working with elderly persons with HIV, of course, regardless of age or aging, sexuality, and sexual orientation. And then I included competence, just knowing, having the skills and being able to apply them in this specific population is very important. And then also technology. Social workers need to understand the special communication challenges when using technology. And I put that one in there because of the multiple times that Gene Fibo said something about technology. Um, so these are going into the interventions. There's case management, private practice therapy, which would be macro and micro components, and then support groups and group therapy, which again has macro and micro components. So on a micro level, individually, older people with HIV tend to be in denial or go through denial, anger, sadness, depression, fear and anxiety, stress, and then also HIV associated neurocognitive disorders, also called HAND, which I could do a whole slide on that, but I chose not to. It's just a problem. And then going on with the interventions, there's groups and social networks. Those are both really important for older people, especially just having that social input because they need that anyway, as we've been learning. But even more so when they have HIV. Um, and so increased social support equates to increase in psychological and physiological support and well-being, whereas inadequate social support decreases in access to services and increase in overall functioning physically. Um, I think that's a typo. I'll have to go back and fix it. Sorry. And then women are more likely to report a lack of social support, and mortality decreases. Mortality decreases the level of social support systems. The one um, therapy I chose to talk about is narrative therapy, and that can work in groups or with individuals. And I think when I read about groups, I thought it was really interesting. The research I read was really cool. Um, but when it works and the facilitator is a good one, group members are really able to share their stories and like I say in here, make new friends, which is really important to them, especially if their families are gone or don't live close by. Um, and they get like a built-in support with a group. And then individually narrative therapy. I love that. So it's a process of telling your story, and then um, the therapist helps you to retell it. I'm sure you guys remember from class. Um, Right, and then I included some alternative interventions. So I put in a section about don't go away, telephone delivered therapy. And hopefully most of you are doing this if you're in field. I hope you're able to get that client contact. I know we've had to switch to that. But the same can be true for elderly patients, especially ones that don't have access to transportation or can't drive. This is a great alternative for them. Um, and then, especially with HIV and AIDS, they might be too sick to travel. So, this is a really good option. And then other alternative interventions for anybody really with HIV or AIDS is mind-body medicine, mindfulness, herbal therapies, touch therapies, and aromatherapy, which I included a little picture. Thought it was pretty. I know. Uh, so, and then macro level supports. Um, so these facts are according to the Administration for Community Living, um, which the CDC partners with them. So that's like health department and community-based organizations providing services. There's there's $130 million awarded between 2014 and 19 just to community-based organizations and health departments and healthcare organizations. And then some, another great organization is Act Against AIDS. They're a group that raises awareness and fights stigma, risk reduction with at-risk population. That's a really cool organization. And then Let's Stop HIV Together is another one. And then there's one called Doing It, which I think is kind of funny. But there's a bunch that, I mean, the supports and agencies for HIV and AIDS are endless. About 10 minutes. And then other macro level or state funded. I included California has a great program. And actually, that's 17% of all AIDS cases are in California. So you can imagine they have really good services there. They have state funding for grants, and they offer interdisciplinary teams with like nurse case manager, social worker, sorry, skilled nursing, domestic assistance, all kinds of stuff. That's like one of their big services that they offer, where a patient would receive all that if they were sick. These are the questions to consider. What interventions do you guys feel would be most beneficial to implement with older persons with HIV? What do you think is the number one struggle for older persons with HIV or AIDS, such as discrimination, stigma, lack of health care, lack of mental health care, lack of support from family, friends, support groups, and or macro level organizations? And number three, how do we provide support to a population whose social networks are decreasing every day due to mortality, children moving away, isolation? So those are my questions, and these are the references. And that's it. That's all I got. So, oh my gosh, I'm so glad I'm done. Okay, guys, well, good luck and